much again. So we'll move on now. So we've dealt with mitral valves. That's done and dusted. The answer is we need a randomised trial. Thank you very much. And we'll move on to the aortic valve. And Mark Dweck is going to talk about watchful waiting versus early surgery in asymptomatic severe aortic stenosis. Mark.
Good afternoon, everybody, and many thanks for the invitation to come and speak here. So I'm going to give a pretty similar talk in some ways, but this time looking at the far superior valve, the aortic valve. And as we all know, that the valve aortic stenosis is characterized by progressive narrowing and calcification of the aortic valve. But I think increasingly we're appreciating that when it comes to the development of symptoms and adverse events, that we also have to carefully consider what's happening in the left ventricle and how that is responding to the increased afterload that is imposed upon it. And what's interesting is that when you look at the association between how much hypertrophy you get and how severe your aortic valve narrowing is, it's not very good. These are two MRI studies comparing against the peak velocity and the aortic valve area, and the correlation is at best weak. So there are multiple other factors that feed into the degree of your hypertrophic response, how quickly you're going to decompensate, other than just how narrow your valve is. I think making the argument that we should be paying close attention to the myocardium as well as the heart valve. Of course, we've failed spectacularly to slow progression in the aortic valve. First ourselves and then later Simon with his study. Both failed to show an impact of statins on the progression of aortic stenosis. And so we're left with aortic valve replacement. And really our major role in the treatment of patients with aortic stenosis is trying to time optimally when we're going to replace the valve. So we don't want to replace it too early because then you're exposing the patient to the risks of surgery and more importantly the risks of having the bioprosthetic or metallic valve and the associated anticoagulation. We don't want to, however, replace it too late because then the myocardium may have sustained irreversible scarring and damage that down the line is going to leave the patients with heart failure and adverse events. So the answer is we want to get it just right. And when is just right? Well, it's just as the ventricle is starting to decompensate, not before and not too late afterwards. So we have to try and identify this decompensation in order to be able to time the replacement correctly. So here are the guidelines, and as we all know, if we're going to replace a valve, firstly we need severe narrowing, that's the valve side of things, but also we need evidence that the ventricle is starting to decompensate. And most commonly our evidence of that is the development of symptoms in patients with aortic stenosis. Occasionally we also are guided by the ejection fraction. And as you can see, the level of evidence supporting that guideline isn't perfect. And usually when you get into this discussion, someone puts this slide up and everyone kind of accepts it because I guess maybe Brownwald is on the paper. But if we just take a minute and have a look at this slide in more detail, I think there's two things to me that stand out. The first is that the data is from 50 years ago, 1968. So is that really applicable to the patients that we're seeing now? And I'm not sure it is. And the evidence for that is the x-axis here. Because look at the age of these patients. We're talking about patients in their 50s and 60s, not the patients that we're seeing every day in the clinic, which are much more towards this end of the spectrum. And so I think increasingly we're finding that symptoms are difficult to interpret in the elderly patients that we're discussing in TAVI meetings and seeing in our clinics. And I think there are several different reasons for that. One is comorbidities. So a lot of our elderly patients have lung disease. They may have coexistent coronary artery disease. Assessing symptoms in these people is difficult and accurately attributing it to the valve. And the second is that these patients may have reduced mobility. This is actually my great uncle, who's a bit of a cantankerous old man and walks with a stick. And he had aortic stenosis and was asymptomatic, followed up in the clinic for many years, before he finally got his valve replacement. And he's now been left with recalcitrant heart failure following that. And I think there's no doubt that we replaced the valve too late in that case. And it was difficult because his mobility was very limited by his stick. So I guess the question is, can we do a better job than our current approach? And to me, there's probably two options. One is that we forget about the myocardium, we put that to one side, and we just look to replace valves in patients who have severe aortic valve stenosis. And there are some proponents of that idea. And the second option, which I'm more in favour of, is that we develop more objective markers of left ventricular decompensation to better guide when we're going to replace the valve. So what about replacing the valves in all the patients with severe AS? I think there are some pretty good arguments in favour of that approach. I mean, the first is that on the face of it, it is simple. And for that reason, it can be widely adopted. We're not talking about lots of complex tests, lots of difficult algorithms. And indeed, it is likely to prevent the development of left ventricular decompensation in a lot of patients. It is backed by some non-randomized observational data. There's a paper in circulation from Korea 5 or 6 years ago suggesting that in people with very advanced valve narrowing, more critical valve narrowing rather than severe, there was some benefit, but that was non-randomized. And of course, the valve manufacturers are very interested in this idea because they're going to sell a lot of TAVI valves if we start whacking TAVIs into everyone. But there are strong arguments against it, I think. Firstly, it's not always absolutely clear that we're dealing with severe aortic stenosis. If you look at recent studies, in about a third of patients who have moderate or severe aortic stenosis, there is some discrepancy in the echo data where we're not quite sure if it's moderate or severe, and that's only explained in the minority by low flow status. The second is that often you can't just disentangle what's happening in the valve from the myocardium because they are closely related, such as in people with low ejection fractions or low stroke volumes. And secondly, we may be exposing patients needlessly and too early to the risk of valve replacement. And that's a particular worry when we're putting valves into younger patients, when biprosthetic valves last less long in younger and younger patients. This is a shameless plug as well for another study that we're doing, which is looking at new treatments trying to slow aortic valve progression. I think this is one of several studies being planned or underway, and we are looking at new medical therapies trying to slow aortic stenosis progression, which I think again argue just against routine replacement of valves. So the other potential strategy is to try and develop more objective markers that the ventricle is failing. So if we go back to the underlying pathology, we all know that if you have aortic stenosis, you have an increased afterload, and that triggers a hypertrophic response, which for many years, if not decades, is compensatory. However, with time, this hypertrophic response decompensates and patients transition to heart failure. And the pathological study suggested two processes driving that, myocyte cell death and associated fibrosis in the left ventricle. Of course, at some stage along this transition, people develop symptoms, and that's traditionally how we time our valve surgery. But our hypothesis really when we started looking at this is that maybe we could develop more objective markers of this decompensation process. And in particular, we looked initially anyway at fibrosis. So if you want to detect myocardial fibrosis, then the gold standard imaging technique is MRI scanning. Traditionally with the latent gadolinium enhancement technique, which is showed in these images here, you have a normal looking black myocardium here, and areas of scarring or fibrosis appear white. And sure enough, in patients with aortic stenosis, you can detect these areas of scarring in patients with advanced disease. The other kind of newer approach is T1 mapping, which can detect earlier stages of the fibrotic process, and that is being extensively investigated but isn't quite as mature as the latent enhancement data. But using these techniques, you can start to divide what's happening in the ventricle into three groups. And so we can look at patients with aortic stenosis and say they have a normal myocardium with no evidence of myocardial fibrosis. At the other end of the spectrum, we have patients with late enhancement and overt scarring in their ventricle. And then in the middle, we have patients with the earlier diffuse interstitial fibrosis. And if you look across those three groups, then they have increasing parameters of left ventricular dysfunction as you move across it. So they have more myocardial injury detected by troponin. They have greater evidence of diastolic and systolic dysfunction. They have worse NYHA scores, worse Kansas City health care questionnaires, and 6-minute walk tests. And crucially, they have a worse prognosis with patients with replacement fibrosis having a pretty bad outcome out to several years following their scan. And in fact, there's quite good data supporting this now. If you have this scarring in your ventricle detected on MRI, there's at least 3 cohorts now that show that you have an adverse outcome, as bad as if you have a myocardial infarction. There's been studies looking at this fibrosis and what happens to it after you have an operation. And what's clear is that when you have this scarring, that's it. You are stuck with it. The fibrosis does not go away following the surgery. So any scarring that you accrue during the time when you are waiting for your operation is going to stay with you long after the surgery. And we are looking at what happens when we're waiting on patients, when we're pursuing this watchful waiting approach. This is unpublished data, but we see clear evidence that the fibrosis accumulates during that time. And if we assume that that this is irreversible, then what we're doing is we're leaving patients to develop scarring in their ventricle without intervening. So I think in summary, we are very interested by this late gallium enhancement technique in aortic stenosis because it's a direct measure of left ventricular decompensation in aortic stenosis. It's irreversible and it's associated with an adverse prognosis. The problem with MRI scanning, particularly when you go elsewhere in the world, I think we're early adopters in the UK with MR, is that people are worried about its expense and its availability. And so we've also explored whether there are cheaper biomarkers of fibrosis in the ventricle. And the first thing that we looked at was the ECG strain pattern. So we all learnt about the strain pattern at medical school and in our training, but the mechanism for that has been unclear up until recently. So we looked at patients who had left ventricular hypertrophy on their ECG and also patients with left ventricular hypertrophy and strain. And the key difference on biopsy was the presence of fibrosis in the strain group, here shown in the pink staining on the slide. And actually, when you looked at MRI findings in these patients, every single person that we looked at who had strain on the ECG had evidence of the fibrosis and scarring on their MRI scan. So the converse wasn't true. It wasn't as sensitive to the fibrosis as the MRI, but certainly it seems to be a specific marker of left ventricular scarring and decompensation in aortic stenosis. And of course, we've known for a while that it's associated, like mid-wall late enhancement, with an adverse outcome in these patients. So potentially, this is an important finding when we see the strain pattern on our patients with who've had an ECG. The second thing that we looked at, coming back to our diagram, was the other process driving the transition from hypertrophy to heart failure, and that was myocyte cell death. And we've got a strong interest in high-sensitivity troponin I assays up in Edinburgh. Particularly Nick Mills and Dave Newby have been driving this in a range of different conditions. So we looked at troponin in our aortic stenosis population. And what we found was that in these patients, your troponin levels are not related to your burden of coronary artery disease, but instead they relate to the hypertrophic response of your left ventricle. So in particular, the degree of left ventricular hypertrophy and also whether you had fibrosis in your ventricle or not. So again, this appears to be a marker of LV decompensation in aortic stenosis. And like the other markers, it was associated with adverse long-term outcomes. The final thing we looked at was, I guess, a composite of those things, along with some other parameters, to try and develop a score for left ventricular decompensation. And if you put it all together, then it seems to work better at predicting the presence of fibrosis than just looking at one thing in isolation. And again, we have the adverse prognosis associated with the decompensation. So I think in summary, we can start to detect the early signs of left ventricular decompensation in aortic stenosis using troponin to look at cell death and looking at MRI and the strain pattern on the ECG to look for fibrosis. And so really the question that we've now turned to is, can we start to use that clinically to better guide the treatment that we offer our patients? And I guess our vision for this is that you would use the troponin and the ECG to screen the patients in the clinic. We're not proposing MRIing all of these patients. We don't think that's reasonable. But if patients have evidence of decompensation with these cheap and simple tests, then we would propose an MRI scan to confirm whether they have scarring in their ventricle. And if they do, then we would say, well, they've got evidence of decompensation and they should have a valve replacement. And we've just received funding really to test that hypothesis from the Sir Jules Thorne Award. And early next year, we'll be starting the Evolved AS study, which is essentially a randomized controlled trial of early surgery in asymptomatic patients with aortic stenosis, but who have objective evidence that their left ventricle is decompensating. This is a summary, really, of the study design. And as discussed, we're going to take people with advanced aortic valve narrowing. We're going to screen them with troponin and ECG. And really, I think the value of troponin in this case is the normal troponin. So high sensitivity troponin I's of less than 6 nanograms per litre. If you have that, then we're going to say that your ventricle is healthy. We don't need to see you. We don't need to do anything right now, but we'll keep watching you in the clinic. However, if your troponin is elevated or you have the strain pattern on your ECG, then we're going to do an MRI scan to confirm that the troponin is due to your aortic stenosis. And if you have evidence of scarring in the ventricle, then you're going to be randomized to either early surgery or TAVI at the clinical team's discretion, or to the standard of care as delivered by the clinical team. And the study is powered off clinical events. In particular, this composite endpoint of all-cause mortality, and we've actually changed it slightly to unexpected hospital admissions due to aortic stenosis. So these are the centres that have signed up. Many of you in the audience are involved in some way with the study. We've worked out that to get to the final 400 patients, we need to screen probably about 1,500 patients. So that it's quite a big undertaking to find these patients and then to get them to agree to participate and to be randomised. And we're looking forward to the results. So in conclusion, I think that the current strategy in how we time aortic valve replacement is somewhat limited, and particularly difficult in the elderly patients that we see with lots of comorbidities. And so if we're starting to think about different approaches to optimize that, then the two that are being investigated and explored are early surgery for everyone with severe aortic stenosis, and then a more targeted approach where we're trying to objectively work out if patients are starting to develop left ventricular decompensation. I'd like to thank you for your attention and all the many people that are involved in this work and the trial. Thank you.
Thanks, Mark. I mean, this is clearly a very interesting and rapidly evolving area. Yes.
Hi, Mark. I just thought I'd get in before Professor Chambers does and say that I'm a bit surprised that you haven't included exercise as part of your screen for LV decompensation, or exercise-induced biomarkers, thinking about Lancelotti's data.
So we haven't excluded it. So if you're in the standard of care arm, then exercise testing can be used at the discretion of the physician. But when we've looked at it in our studies, the number of patients that can actually perform the exercise test is around 50-60%. And so
that treadmill exercise.
Yeah.
So we do bicycle.
Sure. And so we then looked at the 6-minute walk test as an alternative parameter. And the data that we get back from that has been very difficult. It doesn't really correlate with any of the other biomarkers of decompensation that we have. So obviously we thought very carefully about that, about including it in the trial. But in our mind, we find that the troponin and the MRI are potentially more useful.
And finally, I think you and I have probably had this discussion before, but why is it really better to go to the trouble and expense of an MRI than just to carefully track the long axis function by echo?
So, yeah, I think the limitation with the long axis function by echo is that it's not specific to the aortic stenosis disease process. So a lot of these patients have coexisting coronary artery disease. How do you know that the reduction in longitudinal function is related to the aortic stenosis and not to the coronary artery disease? And I think...
But does that matter in terms of outcomes, what it's due to? If they start to lose their LV, they're starting to lose their LV.
But if you have mild aortic stenosis, well, if you have aortic stenosis and your ventricle is healthy from the aortic stenosis point of view, what's the rationale to replacing the valve? I mean, I think it comes back to the argument you just replace it in everyone, whereas we're trying to be more targeted and looking for evidence that the ventricle is failing due to the aortic stenosis.
I'll stop after this, but if you want to restore patients to a normal or as close to normal as possible life expectancy, then you do want them to have normal myocardium at the end, regardless of what's caused it.
But if they've got an infarct, then how are you going to reverse that with an aortic valve replacement? They've got an infarct.
Any yes.
NT-proBNP?
Yes, so I thought someone was going to ask me that. So I've got a slide. I think there's a kind of gradation of when these things start to change, all these different potential biomarkers. And in our experience, the changes in BNP are quite towards the end of the spectrum. They're once people start to develop this systolic dysfunction. And I therefore think that if you're waiting for the BNP to go up, you might be waiting too late. Plus you get into arguments of cut-offs and difficulties with that. The advantage of the troponin is that it does seem to change earlier in this process. And also, if you look at lots of different conditions, I think high troponins, high sensitivity troponins are quite difficult to interpret because there's so many different things that feed into that. But actually a truly normal high sensitivity troponin is associated with an excellent prognosis in a whole range of different conditions. And I think that's similar in aortic stenosis, and so is useful clinically. If you see a normal troponin, we think that's useful. You can be pretty reassured that ventricle is okay at the moment.
Guy.
Mark, sorry. Yeah, there's a discrepancy between the sort of MR description of hypertrophy and the echo description of hypertrophy, isn't there? Where the difference between measuring mass effectively and measuring wall thickness. Yeah. Do you think that wall thickness, which is often a real problem, particularly in low gradient phenotype development, is telling you something different from left ventricular mass?
Yeah, absolutely. I mean, I think as you say, you can have quite marked left ventricular wall thickness with a normal mass because you've got a small cavity, and because of that, in these patients with low flow, low gradient aortic stenosis, they, you don't detect those patients with the mass, but we know that those patients have quite advanced fibrosis that is potentially more closely linked to the wall thickness than the mass.
Yeah, I was interested by that, and also, I think allied to that is the increasing problem we all see is with all the discrepant results, you never really quite know what severe aortic stenosis is, and therefore using advanced techniques, fibrosis mapping, are we picking up an antecedent phenotype that you should be thinking about intervening before you reach, if you like, a conventional marker of either a valve area of 1, an index valve area of 0.6, or a gradient of 40?
I mean, potentially, I think you still need both. You still need to be reassured that the valve was truly narrowed, and that this isn't, for instance, all hypertensive heart disease, which could give you a similar appearance on the MRI scan. But I think we're increasingly appreciating that the interpretation of the echo can be difficult in these patients, and so turning to other imaging modalities to help in the assessment, I think, is useful. And it's not just MRI. I think CT calcium scoring is particularly useful in that context.
Yeah, I mean, again, more of an observation, I suppose, in the question. I think what this whole area emphasises is that the measurement which we rely on conventionally to assess LV function ejection fraction is really a very limited use in this situation, particularly with hypertrophied ventricles. And secondly, there is no doubt that there is more to aortic stenosis than simply the narrowing of the valve, and the individual response to that degree of stenosis is highly variable, and there is no doubt that there is a phenotype where you get excessive hypertrophy and probably associated with that excessive fibrosis, which clearly does seem to indicate a poor prognosis independent of the severity of the valve, and it's those individuals that we need to be identifying, and I think this is the way to do it. It's a very, very interesting trial. We have, yes, one comment, which probably better be the last one before we break for tea. Yep.
So that's all really interesting about your study. So with your crystal ball, if you assume your hypothesis is correct, what impact do you think it's going to make on the treatment of aortic stenosis? Is it a different population? Is it earlier intervention? Or are we going to be excluding patients? Do you think it's going to change things?
Yes. I think we'll end up operating earlier in lots of these patients. The other side of it that we're not really looking at in this trial is, I guess, the futile case in people who have very advanced, irreversible fibrosis in their ventricle, low ejection fractions. I think MRI could be quite useful in that as well, because in those patients, you wouldn't expect their ventricles to pick up following surgery, and so MRI may help avoid surgery in some people at that end of the spectrum, but certainly in the context of this trial, it's basically a trial of earlier surgery, but not in everyone, in targeted people.
At which point I think we should